Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Ali, 35 years old, presented with hemoptysis for 3 weeks. Please take history, examine the patient, and address his concern. I will share the timer, then you can start. Ready?
Yes.
Yeah. Here you go.
Hello there. I'm Dr. Abdullah, one of the doctors in the clinic today. Am I speaking to Mr. Ali, 35 years old?
Yes, doctor.
Nice to meet you, Mr. Ali.
Nice to meet you, doctor.
I know from your notes that you have coughing, you have trouble with the coughing up blood. Can you tell me more about it, please?
Yes, doctor. This started for me since 3 weeks ago.
Can you just tell me, is it the first time you have this?
Yes, first time, doctor.
Okay. Can you tell me what is the color of the cough of the blood? Is it like fresh or like black, brown?
Fresh, doctor.
Okay. And can you tell me, it's like red, bright red?
Yes.
Okay. Tell me what is the amount of it? Is it large amount, or can you quantify the amount for me?
Moderate to large, doctor. It started small but increase.
Okay. And how frequently you are coughing up this blood?
4 to 5 per day.
Mr. Ali, don't be worried. We will try our best to help you and to reach the diagnosis by the end of this by the end of this session.
Okay, thank you.
Okay. And do you have any chest pain with this?
No.
Any like chest discomfort or tightness?
No, doctor.
Okay.
No.
Any flame beside this blood?
Yes, sometimes, doctor. Even this flame, it contains blood.
Okay. What is the color of the flame?
Like whitish.
Okay. And is it like offensive?
No.
Okay. Do you have any noisy breathing?
Sometimes, yes, doctor.
Okay. Do you have any difficulty breathing or shortness of breath?
Yes.
Okay. Do you have any high body temperature?
No.
Okay.
And just doctor, I feel like fever when I am going to check my temperature. I detect it like 37.3.
37.3.
Yeah.
Okay. Do you have any racing of your heart?
No.
Any like fainting or blackout?
No, doctor.
You told me you have shortness of breath. Can you tell me more about it? Is it when you are at rest, or when you are walking, when you are exerting yourself?
Actually, it happened for me mainly with exertion, doctor.
Okay. Do you have any shortness of breath when you are lying down?
No.
Any shortness of breath that awake you at night, searching for air?
No, doctor.
Any leg swelling?
No, doctor.
Okay. And since 3 weeks you have this symptom, is it like stable or increasing or decreasing?
Yeah, doctor. Is it like it become worse, and the blood amount it become more?
Okay. You told me you have like you measured your temperature. Do you have any like nighttime fever?
No, doctor.
Any sweating?
No.
Do you have any weight changes, like weight loss?
Yes, doctor. I lost 3 kilo.
Okay. Over how long you lost it?
Yes, before 3 months.
For 3 months. Is it intentional?
No, doctor.
And how about your appetite?
It's good, doctor.
Your appetite is good. That is good.
Yes.
And do you have any, like, do you notice any itchiness in your body?
No, doctor.
Okay. Any lumps or bumps?
No, doctor. We can check it. Yeah.
Okay.
I'm not
Any
sure.
weather? Okay. Any weather preference?
No,
Like you
doctor.
prefer cold weather or hot weather?
No.
Do you have any dizziness on standing from sitting position?
No, doctor.
Okay. Have you noticed any bleeding from other side, like from your nose or from back passage or under your skin?
Actually, yes, I'm not bleeding per nose, doctor, before this.
Mm-hmm. But when is that exactly started?
Yes, sometimes within 3 weeks. This 3 weeks.
You have this bleeding once?
Yeah.
Okay. Do you have noticed any like runny nose or crusting around your nose or any deformity?
Yes, doctor, there is crusting in my nose and
Okay.
stiffness.
Okay. And do you notice any skin rash?
No, doctor.
Okay. Any joint pain or swelling?
Yes, doctor, I have joint pain.
Okay. Where exactly? Which joint you are?
Yes, sometimes the joint of my hands and sometimes my knee, my elbow.
Mm-hmm. Do you have any stiffness in your joint, like morning stiffness?
No, doctor.
Okay, that is good. And Mr. Ali, are you taking any blood thinning medication, like
No,
warfarin?
doctor. No.
Okay. Can you tell me, do you have any? Do you have any? Do you traveled recently anywhere?
No, doctor.
Okay. Do you have any history of blood clot or blood disease?
No.
Do you have any family history of blood clot or blood disease?
No, doctor.
Do you notice any swelling in the back of your legs?
No.
Okay. And so, Mr. Raleigh, do you have any history of long-standing medical condition that should be aware of?
No, doctor. I'm
Any
quite
history
well
of,
before this.
okay. Any history of high blood pressure, blood sugar, any history of heart disease or lung disease?
No, doctor.
Okay. Any history of surgical operation
No.
or blood transfusion?
No, doctor.
Okay. And any family history of family history of note?
No.
Okay. Mr. Ali, do you have any headache?
No, doctor.
Any vision problem?
No.
Any red eyes or itchiness in your eyes?
No.
Okay. Do you have any dizziness or loss of consciousness?
No.
Any pins and needles or altered
No.
sensation? Do you have any
No.
weakness in your body?
No, doctor.
Any shaking?
No.
Do you have any loss of your bowel or water work?
No, doctor.
Okay. And what's about your bowel habit? Is it okay?
Yes.
Okay. Do you notice any soreness in your mouth?
No, doctor.
Any difficulty swallowing or painful swallowing?
No.
Any tummy pain or swelling?
No.
Do you have any yellowish discoloration of your eyeball?
No, doctor.
Have anybody told you that you look paler than usual?
Yes.
Uh-huh.
Yes,
Somebody commented that you are paler than usual?
Yes, doctor.
Okay. And do you have any alteration in your bowel habits?
No.
How about your water work?
Yes. What do you want to know?
I want, is there is any change in the frequency or the amount?
Yeah, no change in the frequency or amount, doctor.
Okay. Any change in the color?
Yes, doctor.
And can you tell me more about it?
Yes, it become more red, doctor.
Have you noticed any blood in your water work?
I didn't sure regarding this. Just the color changed to red.
Any flanks pain or back pain?
No.
Any frothiness in your urine?
No.
Nice. And Mr. Ali, can I ask you a private question?
Yes, you can.
Are you married?
Yes.
Okay. Do you have any extramarital relationship?
No, doctor.
Do you have any tattooing in your body?
No.
Any sharing needles?
No.
Any body piercing?
No.
Okay. And so, Mr. Ali, do you smoke?
Yes, doctor.
How many cigarettes over how long you are smoking?
Yes, 7 to 10 cigarettes per day since 5 years.
Okay, Mr. Ali, I highly advise you to stop smoking because it's adversely affecting your health. And if you wish, I can refer you to smoking cessation clinic. Is that okay with you?
Okay, okay, doctor. Thank you.
Okay. Do you drink alcohol?
No, doctor.
Okay. And can I know what do you do for your living?
Yes, doctor. I'm teacher.
How is this affecting you?
Just since it started this condition for me, I'm not able to go to work because I have tiredness, doctor. Also.
Okay. We are very sorry for this, and we are trying our best to help you with this. And we can give you sick leave if you are not able to cope with your work until we will solve this problem.
Okay. So, thank you, doctor.
Okay. And can I examine you?
Yes, you can. What do you want to do?
I will examine I will inspect first the hands. Anything in the hands?
Like what, doctor?
Any like deformity or any rheumatoid
No.
like? Okay, I will check the pulse. Is it regular?
Pulse 100 regular.
100 regular?
Yes.
Okay,
Yes.
I will just see if there is any. I will just examine his eyes for pallor and jaundice.
No, patient pale, not jaundice.
Okay.
2 minutes left.
And I will just examine his chest. If there is anything in the examination of the chest?
No.
Nothing. The breathing, there is any crackles or crepitations?
No crackles, no crepitations.
Okay, I will just see if his nose, if there is any deformity in his nose.
Yes, there is deformity.
Okay, I will just palpate the abdomen. Is there is anything?
No.
Okay, I will see the skin of the patient. Is there is any rash?
No skin rash or skin change.
Okay, I will examine also the lower limb. Is there is any edema?
No.
So, Mr. Ali, can I ask you what's your concern?
Yes, doctor, what I have?
So,
is it cancer, doctor?
I highly appreciate your concerns. From what you told me and after examining you, I think you have condition called you have a condition called vasculitis. It is one form of the vasculitis. It's a medical condition. Don't bother about the name. It's a condition when your defense system is getting misdirected instead of attacking the germs and the bugs, is attacking the, for example, in your conditions, the kidney and the lungs. For that, we need to admit you and we need to do some blood tests and imaging. And after that, we will have another meeting with you. And for your concern, is it cancer? It is less likely you have this cancer, but we need to exclude it. Do you have any other question?
No, doctor.
Okay, thank you for talking to me today.
Thank you, doctor.
Thank you.
Perfect, on time. Time is up. Let's start examiner questions.
Okay. Could you present your case for me?
Yes, I have examined this 35 years old male who presented with hymoptysis for the last 3 weeks. He also has a history of upper respiratory infection and, he has a history of nasal crusting. Also, he has history of weight loss, and also he has a history of epistaxis started, and also joint pain and low grade fever for the same time, and tiredness. On examination, I couldn't find anything. He has anemia or a pallor on the examination. The chest examination is normal, and I couldn't find any peripheral finding in the hands of the patients. My differential for that is Wagner granulomatous causing this symptom of the patient.
Okay. So what is your differential diagnosis?
My differential diagnosis, it could be infection, a sort of infection, tuberculosis, and it could be pneumonia also that's causing this. I thought also of could be a pulmonary embolism, but in the history there is no any feature suggesting pulmonary embolism, and also I thought of the cardiac causes, like he's having mitral stenosis as cause of his hymoptysis, but also in the history no features. The list at the bottom of my list I put the cancer, but the patient is young and he has no any risk factor and any red flags. I couldn't find any red flag in the history.
Okay. So what is your plan of management for this patient?
The plan of the management.
Including the treatment? Yes.
I couldn't hear you.
I mean investigation and the treatment for this patient.
Investigation, I will start by basic investigation, including full blood count, looking for the anemia. He has a pallor, and it will do also clotting like INR and PTT. We will do the kidney function test to see if the kidney is functioning well, electrolytes, and liver function test also, inflammatory marker. Specific investigation, I will start by doing chest X-ray to see if there is any cavitation or any feature of tuberculosis. And I will, if it's not the chest X-ray, I will proceed to the CT chest, and I will do vasculitic screen, C ANCA, B ANCA, ANA, and I will do what else? I will do
anything else?
blood culture and sputum culture also, and urine analysis.
Okay. Do you want to add anything in investigation?
It's not in my.
Okay. What is your management? What is your treatment for this patient? How can you treat it?
The treatment would be multidisciplinary, including non-pharmacological patient education counseling about his condition, and multidisciplinary team approach, including the pulmonologist and nephrologist. We will start by giving the patient immunosuppressant. We will start by the steroid, methylprednisolone, and immunosuppressive medication like cyclophosphamide.
Okay. If your patient he has massive hemoptysis,
We can try the pulmonary artery embolization to stop the bleeding.
Okay. So any other things? The treatment after this steroid and immunosuppressant?
Like what? Oh, sorry.
Okay. Okay. Like biological rituximab. If your patient has massive hemoptysis, we can do for him plasma exchange also.
Okay.
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 Now finish now.
Yes, I have one more question. If the kidney function is worsening after starting cyclophosphamide, you give option of cyclophosphamide. What if this patient still having kidney affection?
You mean cyclophosphamide and the patient having kidney infection?
Yeah, not responding.
We can change to another immunosuppressant like azathioprine.
Okay, would you consider the dialysis, I mean, or plasmapheresis? Plasmapheresis, yes, one of the options.
Yes.
Yeah, plasmapheresis, okay?
Okay.
If there is kidney failure, we can consider renal replacement therapy.
Okay.
Okay, thank you, Dr. Tasneem and Dr. Sarah. Well done. Let's start with Dr. Sarah comment. Sorry, Dr. Tasneem comment, then I will comment.
Dr. Sarah, you mean?
Yes.
Okay, I forget who started. So who was the candidate?
No problem. Yeah.
Yeah, Dr. Tasneem was the candidate. So start, Dr. Sarah, please, the comment. The case was about what?
Yes. Actually, before I will explain for this case, she did great, but she took a long time in the history and also delayed the analysis of renal. Okay, in the history.
Yeah.
Regarding the differential diagnosis, yes, the diagnosis is Wigner's granulomatosis, and other differential, we can put chronic infections like tuberculosis, HIV. So we need to exclude it in the history and in the examination also. And also we can put lung cancer because this patient, he has a smoker. Okay. At the bottom, we can put pulmonary embolism, but again, is that a long time? This patient 3 weeks ago. Okay.
Okay.
Regarding the investigations, you miss renal biopsy for these patients. It is important. And also tuberculosis screening.
It's not only renal biopsy. They can take from the airways. So the most easy and accessible, the airways, right? Less invasive. Okay, continue. Yeah.
Yes. Also, we need to do tuberculosis screening, sputum analysis, or PCR for this patient. Okay. After that, no added informations. You did great. Yes.
Yeah, I agree with you, Sheen. Thank you, Dr. Sarah, for this case. Well done, Dr. Tasneem. I'm agree with Dr. Sarah that the history was very long. You start examination at the minute 12, right? So was 1 minute missed or 1 minute left to the concerns. So you have to start examination earlier, maybe at minute 9 or maximum 9. You have a lot of finding in this patient to examine. Okay. By the way, the chest examination, you will not say as a question any symptoms or any finding in the chest examination. No, you will do all the steps of a chest examination: inspection, palpation, percussion, auscultation. Because this is a case of hemoptysis, you have to examine the chest, full examination. Okay.
Okay.
Apart from the examination of the chest, of course, the nose, the deformity, the airway, you can open his mouth, and the other joint affection, because there is also joint examination you have to do because of joint affection. You can offer at the end, especially if there is a history of epistaxis, you can offer also examination of the nose already done, but I mean by ENT, we can refer to the ENT, but I think no scope to examine the nose in paces. Offer examination, you would like to complete examination by doing digital rectal, although no blood in the on the back passage. Back to the history. You did examination, it was concise one because it was short time. But here you have to do full chest examination. At least it will take from you 3 to 4 minutes. Agree?
Yes, yes.
Back to the history. I think also the history was little bit disorganized because you ask question systemic review, then back to the complaint and the relevant system. Sorry, then you ask again about the social and family history. Then you ask again about some question in the systemic review, like GI, for example. You ask about difficult swallowing and tummy distension. Later on, you ask about any change of the bowel habit. Try to make your questions once. I mean, if you ask about the systemic review, try to finish the systemic review. Even if you remember something to roll out as a differential diagnosis, for example, you can ask it later on or earlier. Again, I prefer the approach I always repeat every session, starting by the complaint, analysis of the complaint, onset, course, duration, timing, and what increase, what decrease. In this scenario, you have to add 3 questions, and you already ask all these questions, although it was scattered. You ask about blood thinning medication, which is good question. You ask about, you didn't ask about trauma, right? You have to ask about trauma because he has blood from 2 areas. And the other medication, blood thinner medication, or blood coming from any other area in your body. This question is important whenever you have a complaint of blood loss, either uh, hemoptysis, epistaxis, even melena. You have to ask all these questions. Any blood coming from other areas, or any blood thinner medication. And some patients you can ask about trauma. In this patient, you have to ask about trauma. He has deformity along with epistaxis. So you can ask about trauma, particularly to the nose. What if this case not GPA and it was HHT, for example? So you have to roll out the trauma. It might be the reason of hemoptysis, okay, or epistaxis. Sorry, hemoptysis is not caused by trauma, but I'm talking about epistaxis itself. Okay, back to the history, relevant system, and you ask already about the constitutional, which is very good timing. You ask about it, but you have to add to them loss of weight, loss of appetite, the night sweats, night body temperature, lumps or bumps. Here you ask about dizziness. Why? Because you have possible anemia, dizziness, any history of dizziness. Anyone told you you are paler than before? And the other question for constitutional symptoms, particularly in this scenario, yeah, I think you mentioned it. No, you didn't ask about a history of contact with sick patient. Why? Because
Yes.
you can put TB as a differential. Hemoptysis, loss of weight, fever. So TB, one of the possible differential you have to put in your mind. And particular in this case, okay, the same symptoms. If this patient is not GPA and there is no deformity and he has contact with sick patient, definitely it would be TB because the same manifestation, apart of the hematuria. Although hematuria can happen with the TB for medication side effect or even glomerulitis. Anyway, it's not in our case, but you have to ask any patient with hemoptysis, please add to your approach any contact with sick patient. Okay, back to the history taking. You finish already the question. You will ask now about any long-standing disease. You ask it initially, then you repeat the question again about diabetes, hypertension. By the way, if the patient will have history of diabetes, he will tell you, yes, I have diabetes. So no need to specify a question for diabetes or hypertension. You have any history of note or any history of long-standing disease? If he asks you, what do you mean, doctor? Now you can mention diabetes, hypertension. But if he said, no, I don't have, so he ignored it or he denied this, no need to specify or ask again about any history of diabetes or hypertension. Because it's a very common long-standing disease worldwide. Everyone will know either he's hypertensive or diabetic. Other disease, you can name them. For example, you have history of lung disease, in this as in this scenario. You can ask in the family history, which you already you asked. Okay, back to the next step, the systemic review. Systemic review start from the CNS down to the two. Again, as every time I mention, headache, you have any change of the feelings, numbness, weakness. By the way, you might have here weakness or numbness. Do you think, Dr. Tasneem?
Weakness.
Weakness or numbness?
Yes, he can have
Yeah,
peripheral neuropathy or mononeuritis multiplex.
yeah, exactly. Particularly with eosinophilic, more than the GPA. But vasculitis can affect any nerve. So you can put or you can ask, and you might have this in the finding. Okay, this is for the CNS. The next, any intolerance to any weather, rather than saying, do you prefer any weather? Because some patient will tell you, yes, I prefer the hot weather because he like the weather in the summer, for example. But does it mean he is hypothyroidism or yes, hypothyroidism? And the opposite, if he's preferring the winter, he's not necessary to be having hyperthyroidism. So the intolerance, it's the question. Do you have you are you intolerant to the weather, particular weather, either hot or cold? And accordingly, you can pick up the hyper or hypothyroidism. Okay. Next system, cardiovascular. Here you have to ask the question of cardiovascular, particular with anemia. You might have chest pain, awareness of heartbeat. You didn't ask about awareness of heartbeat. Why? Because you ask about cardiovascular while asking the question of the relevant system, right? You miss the awareness of heartbeat totally, which is possibly in this scenario positive because of anemia. But you asked chest pain earlier. That's why you didn't ask about the cardiovascular questions. That's why I prefer to ask systemic review as a package and all together, not scattered question. Okay, of course you ask about the noisy breathing and all this question as a relevant system. So you will not ask about the chest question unless you miss or you forget one question. Here, if you have noisy breathing, what do you think the case will be?
Charges Rouse.
Exactly. So it's important particularly to ask about this question specifically. You have any noisy breathing? Yes, he might be eosinophilic granulomatosis with polyangiitis. If not, sorry, if not, so this is GPA. Back to the history, any GI question, difficult swallowing, any blood coming or vomited or blood, or any blood coming from your, sorry for this question, back passage, or any change of your bowel habit. So I will ask the whole questions for GI once. I will not ask a change of the bowel habit, then I will ask again any tummy pain in another time. They don't like this approach or they don't like to ask the question in disorganized way. Back to the history, the systemic review, the GI, genitourinary. Here, good question you ask about the blood in the urine. But I think Dr. Sarah also helped you when she told you what I don't have any change in the amount or any fourth urine. So you have to ask particularly, do you have any change in the color or you have any blood in the water work? Why? Because it's commonly associated. Then the musculoskeletal, joint pain, skin rash. Possibly you might have skin rash here. It's a case of vasculitis, so you might have any type of skin rash. Finish the approach, the clinical, the analysis, the complaint, the relevant system, the constitutional, systemic review, the family history now or the social history, family history. Travel history is important. Yes, he might have travel history to India or endemic area for TB, for example, not particularly India, any endemic area for
Yeah.
TB. So you have to ask this question, which you already asked. The question for HIV, it's okay to ask, but try to make it faster because difficult to have HIV as presented with hemoptysis, although it's possible. But the case here is clear, so it's okay to ask, but try to minimize the time for asking about the HIV questions. Do you smoke is important? Do you drink alcohol? The job itself, and again, the sick patient, you might ask it here or with the HIV or with the chest, but don't miss the question of contact with sick people. The support, of course, you have to support because he has uh, an ability to cope with his activity or his job. So you can offer him sick leave, which is perfect. You did in this scenario. The concern, already we discussed the examination. Now the concern time. What I have, you already, I like when you mention vasculitis. By the way, be smart. No need to give the syndrome. For example, if you miss the syndrome name, you will be panic. Oh my God, I forget what I can give. But I like when you told him it's a vasculitis. It's not wrong, and you didn't give him the name. Maybe I think you forget, or it wasn't in your mind as a name.
Yes, yes, I just forget the name of the Wagner. Yeah,
Exactly. You
that's
can mention
why
it
I
to the
told the
examiner.
vasculitis.
Perfect. Yeah, I like the answer. Vasculitis. It's one of the vasculitis diseases. So it's okay to mention the term of the disease. Okay. No need to mention the syndrome itself or the disease name unless you forget. So it's need to give. But if you forget, you can give the measure of the vasculitis or the term of the whole management, or sorry, the whole disease manifestation, which is vasculitis. Okay, any possibility to be HIV or cancer? Good, you didn't mention, you didn't forget, because it was one of these concern. You have to give answer for this concern. Then I think any possibility, this question from me, any possibility to be transferred to my kids or children?
It is not inherited. That's mean it's
Perfect,
not run in families.
perfect. However,
However, your
however,
kids have a higher chance than the general
exactly.
population.
Yes, any autoimmune or connective tissue disease, there is possibility to be running in family, not in genetic or inherited way, but they have more possibility than others or than normal population. Perfect, Dr. Tasneem. As a first time, I think this first time to practice with me, you have good approach, the sympathy, the empathy. You are fluent. You're not stopping to think about the question, but try to make your systematic approach little bit organized. Otherwise, you are perfect. The differential, again, as Dr. Sarah said, and you already mentioned, on the top GPA, you can give the other name or the other vasculitis, which is eosinophilic GPA. You can say against that he doesn't have any wheezy or any asthma features. And GPA, I like the
Good
comment.
posture also.
Yeah, good posture is very common. You have to mention
Mm.
any pulmonary renal syndrome. Three of these conditions you should mention.
Mm.
The three conditions, they are differential to each others, GPA and eosinophilic GPA, and the good posture. In this scenario, particularly, you can say you can put HIV or cancer and TB in my differential, and I have to roll them out. The examination time or the examiner time regarding the investigation, I prefer to give the investigation as categorized manner, not everything you will mention. How? Because you didn't remember what I forget what I can do else. But if you systemized your approach, general, bedside, specific, or general, specific, bedside, image,
Mm.
and invasive. Now I will ask you to repeat the investigation in this way, starting by general. What you can find, what you can do, and what you can find.
Can you just repeat it again, please?
General investigation.
Yeah, general investigation like full blood count,
Perfect.
inflammatory marker,
What
uh,
what's expected in the CBC?
The CBC, I would expect that the patient's having anemia, so low
Perfect.
blood count.
Yeah, any type of anemia you can specify?
It's like just normocytic anemia because of the blood loss.
It's acute because acute blood
Yeah.
loss. But if chronic blood loss, it would be
Microcytic.
perfect. Okay, the next.
Specific
No, still in the general. You mentioned CBC. What else is important in this scenario?
kidney function test,
No,
electrolyte,
before kidney function. You have bleeding. What you should do?
clotting, the
Yeah,
coagulation.
coagulation profile. It's simple and routine and important. If there is coagulopathy, I should correct and I should also put other possibility of other disease, right?
Right.
Okay. The next kidney function, you mentioned already the kidney function, right?
Yes. UN.
Liver function. Do you think the liver function here important?
Liver function.
With any
Just to make
bleeding?
it as bad,
Yes.
or it's
By the way, you can say I can do all these tests to be baseline
yes, as bad.
investigation. Any patient admitted for first time, I should do all baseline tests. Why? Because this patient might present again. So I have to know his baseline tests, right? This is what we called routine test. I have to do them just to be sure everything is okay and to be sure this would be in his report to be for the follow-up. Now the time of specific investigation and give me the answer of specific investigation.
Vasculitic screening in form of C ANCA, P ANCA.
Perfect. Okay, what's specific in this scenario? C or P?
C ANCA.
Perfect. And anti-nuclear antibody you mentioned, ANA. Yes. What else? Don't forget the inflammatory markers. It's very important.
Yes, just
Yes, along with ASR, CRP, ProCats. Okay. Now the time for bedside test.
bedside test. I can just dip the urine for the
Perfect.
proteinuria and hematuria.
Any cast, yes, for the cast, particularly blood. Okay. This is the bedside. You can do as well ECG, echo to rule out anemia or anemic heart failure. Just if you can remember. If not, it's not that much important. And if you suspect respiratory affection, what you can do?
Respiratory affection.
Yeah.
I can do just a pulmonary function test.
Okay. And any patient with chest syndrome or chest symptoms, you have to think about ABG, particularly if he has or she has hypoxia. Okay? Arterial blood gas. The next, the image. What image you want to start with?
We'll start by the chest X-ray, and then we'll proceed to the CT chest.
What type of CT chest?
I think here we will do CT with contrast.
Why?
I think the HRCT we will do for the parenchymal lung disease, like interstitial lung disease, but I'm not sure here what type of CT I will do.
By the way, it's upper airway, right? Yeah, there is vasculitis, but it will not be in the CT with contrast. So it's HRCT check for the nodules and to rule out any consolidation if you suspect TB, cancer, and mass. It will not be diagnosing or diagnostic for vasculitis. And the test, the invasive test in this scenario would be the last investigation. Dr. Tasneem? Hello? You can hear me? Hello? Anyone can hear me?
Yes, clear. Your
Yes,
voice is
yes,
clear.
clear your
Yeah,
voice.
okay. I thought from mine. Okay. Maybe something else affected in her connection. Okay, so the invasive here will be Dr. Sarah. I will ask this question to Dr. Sarah.
Yes.
What invasive test you can do here?
For the case, bronchoscopy plus or minus biopsy.
Yeah, this is the definite diagnostic test, by the way. And you can take it from the upper airways. No need to be deeper.
Mm-hmm.
Renal biopsy considered, but I think it's more invasive, so it's the upper airway bronchoscopy biopsy.
Yes.
Yeah, okay. The management plan already mentioned. Anyone has question?
Regarding examination, also lymph nodes should be examined in this
Yeah,
patient
you're right.
and
Perfect.
heart
Yes, cervical and
for
axillary.
heart
Yes,
failure also.
perfect. Yeah, in anemic heart failure. Perfect. Yes.
Yes.
Thank you, Dr. Sarah. Any question from you, Dr. Tasneem? If she joined back, please post your scenario to Dr.
Okay.
Sarah. And yeah, you joined? Okay. You have any question before moving on?
No, doctor, thank you.
Thank you too, Dr. Sarah. Any question? We
No,
can.
thank you, doctor.
Okay. Anyone has comment or question, please.
I have a question, Dr. Basim. In this
Sure.
case,
Sure, yes, Dr. Mohammed.
if the patient raise a concern that I have a cancer, do I have a cancer? So, in this case, in the
Yeah,
how would I answer his concern if
yeah,
he's
perfect. Perfect question. And you will answer this question by yourself. What do you think?
I would tell him cancer is one of the possibility that we need to
Perfect.
rule out.
Perfect. Is it on the top?
Mm-hmm.
No, in the bottom of the
But it's
list.
yeah, exactly. So,
But
so this,
this is why
yeah.
I'm asking if he asks me specific question, do I
What?
have a cancer? So I have to tell him cancer is one of the possibility that we need to rule out. Correct?
Yes, perfect. This
Okay.
is the perfect answer, by the way. But it's not the top differential, but it's one of the possibility. Why? What do you think? If he asks you, doctor, why you are saying that? Why you are suspecting cancer, doctor?
Yeah, because of his symptom, his presentation, he has a
Perfect.
hemoptysis. He's a smoker, and he has lost weight. So
Yes.
yeah.
You give the perfect answer.
Okay.
Okay. So you
Thank-
have to put it in your differential. But there is something, give a clue for the case, which is deformity in the nose. So he might be something else, but still the cancer, one of the possibility. We have to rule it out. That's why we are doing the HRCT chest. If there is big mass, I can consider CT chest with contrast. Okay. Okay.
Thank you.
Thank you, Dr. Muhammad, for your question and your always chat
Dr.
comments.
Bassem, can I
Yeah.
ask?
Sure, Doctor. Dr. Hoda? Yes, sure.
Uh, During examination, if the patient have two problem, like chest and like joint pain, knee pain, how
Mm-hmm.
I will manage the time to examine both system? It's take long time.
Dr. Hoda, it's not. Sometimes you have three system, by the way. It's not two.
Okay.
So you have to arrange your time or to manage your time to finish early to have good examination. By the way, my advice, and I always say this advice, maybe it's less frequent to mention, but I repeat it. And now I please write it in your tips. One, while you are taking history, you have a paper, right? So you can write before going inside the approach which you will follow. Write down in your paper, make a big letter or bold letter, examination. So exam, you make it in abbreviation, exam. What you write beside this word while doing history taking? What do you think? I always saying this advice.
Yeah.
So you will write beside this word what you would examine after finishing the history. Why you are doing that? Because whenever you finish the history taking, you will be with the stress, of course. You will be forgetting what I should examine. You will come after the station. Oh my God, I didn't examine the knee. It was there in the history taking. There was the knee pain. So again, my golden advice: you are taking history, right? I noticed in his history he has tummy pain. I will write in my word in the paper beside the examination, abdominal examination. He has while taking systemic approach, he has knee pain, as you mentioned. I will add to the word down knee examination. If I have time, it's good and great. If I didn't have the time to finish the examination, particularly these things I added while taking history, I'm not talking about the main complaint. Definitely, you will do the main complaint examination. For this scenario, for example, he has chest pain, or sorry, hemoptysis. I will examine the chest from A to Z and the nose, of course. But what else I could examine, as mentioned in the history, I will write joint pain. So I should do first the complaint examination, then the other finding while taking history as examination. I should add knee joint, I should do. If, for example, he has loss of weight, I can think about HIV, so I will do lymph node examination. I will write it beside my word examination in the paper. Believe me, if you will not do this, you will forget what you should examine. Okay, you have a look, you can have a look to your paper, what I wrote to examine before moving forward to the patient. That time you will remember what I should examine. But if you thought that I will do all examinations of everything I got from the history, you will be wrong. Definitely you will miss something. So again, please write it in your paper what I should examine while doing examination of the patient, because the patient will be staying away from you. You are talking to the surrogate. Okay, and that in the office, for example, and the patient will be hidden behind the curtain. You are not talking to the patient in most of the centers and diets. I'm not sure, maybe there is centers you are talking to the patient, maybe he's educated patient, but I don't think so. Okay,
Okay, teacher,
thank you,
thank you.
Dr. Har. Your scenario, Dr. Sarah. Mr. Ahmed, 65 years old, male, known case of diabetes hypertension, presented with confusion for 1 day. His vitals are normal apart from blood pressure 100/60. Talk to the daughter, Mrs. Muna. Okay, I will read the comment quickly until Dr. Sarah will be ready. Dr. Ihda wrote, in this scenario, I should admit this patient and have ABC approach. Okay, let's talk about the admission criteria for this patient. I think Dr. Tasneem did the case, right? You didn't ask about the amount, Dr. Tasneem, which is very important in this scenario. Did you ask?
Yeah, yes, I asked, and she said
Oh,
it's moderate to large amount.
perfect. Okay, sorry, I missed this area. Okay, so what do you think the admission decision for this patient? Will you admit him?
Yes, definitely, because he has a lot frequent also hemoptysis
Not only frequent, so the frequency and
amount also.
amount and anemia.
And yes,
Anemia. He has pallor. Okay, so he has pallor. You have to. By the way, you added one question. I like the itchiness. I like this part of questions as a constitutional itchiness, and in the constitutional symptoms means there
B
is liver,
symptom.
right?
And-
Liver
Yes,
disease, and liver disease, of course, can be complicated with bleeding tendency and hemoptysis or hematemesis, particularly. Thank you, Dr. Ihda, for this remind. HRCT chest, I agree. Cross-matching blood group, perfect. See, whenever you start answering in the systemic way, you will try to collect whole labs, but still you can miss some of them. But if you start to say, I will do C ANCA, B ANCA, and vasculitis workup, you gonna miss a lot of important investigation. One of them, as Dr. I cannot see the name anyway, the cross matching and blood group is very important. Yeah, the biopsy from the nose can be from any from any upper airway. Bronchoscopy, thank you, Dr. Muhammad Omar. Lung cancer, good posture, Dr. Muhammad Omar also. PE, particularly you can add it if there is chest pain. HHT as a differential, if there is skin rash. Plasma exchange, yes, if there is kidney affection, rapidly progression. Wegener disease, by the way, Wegener disease and Sharg-Strauss as the name of the disease It's not anymore. So you have to give the new terms, which is GPA and eosinophilic GPA. Contact with sick patient, yes. Okay. Sorry, Dr. Dua. Sorry, I missed the management. If is it steroid, immunosuppressive, cyclophosphamide? Perfect. All of them are the line of management. Adding to them the biological, perfect, particularly rituximab. Okay, so you have to remember rituximab in whole paces, one of them, the GPA. By the way, there is a other indication for rituximab in paces, but the most important indication in paces for rituximab, one of them GPA and eosinophilic GPA. You can add to them as well.
All right, thank you
Anyone
so much.
remember? Anyone remember? There is another important indication. Pemphigus vulgaris. Okay. Any question before moving to the next scenario?
So, sorry, is it like in acute phase you start with the steroid and then on a long term you
Yes.
start
Any
then immunosuppression?
vasculitis flare up. Any vasculitis flare up, you have to mention pulse therapy or steroid in high dose.
All right.
High dose steroid followed by immunosuppressant, particularly in the GPA. If there is kidney affection, cyclophosphamide.
All right, thank you.
Yeah, most welcome. Yes, Dr. Heda also added thyroid eye disease, rituximab, particularly exophthalmos. If yes, one of the indication of rituximab. If there is exophthalmos and the eye significantly affected. Multiple sclerosis, I think it was natalizumab. I'm not sure about rituximab. Natalizumab, one of the options, not rituximab. If you are sure, you can share it again, please, Dr. Heda, the evidence.
If I just mentioned like biological, if I can't remember which one will it be okay?
Rituximab.
I
In
mean,
our
like
scenario?
in our scenario, it's rituximab, yeah. But
Yes.
like I said, like if I just don't know about which one should we choose. So
Yes,
is
of
it okay
course.
to
You
just
are.
mention like
Yes, of
biological?
course. Definitely.
All right,
By the
thank you.
way, they are not testing how knowledge you have compared to the baseline. Okay? If you have the good basic information, that's enough. Biological. Who will choose by the way, who are the one choosing the name of the biological? Are you the one?
Should be
Multidisciplinary,
yeah,
the multidisciplinary team,
yeah,
rheumatology or nephrologist.
as a
It's not your
specialist.
decision.
Yeah.
Exactly. Okay. So at least give the major group in this scenario in biological therapy. Yes, it's the option. Rituximab in rheumatoid arthritis. Yes, I remember also there is the rituximab or infliximab. I'm not sure. Ankylosing, I remember adalimumab, etanercept. I don't think rituximab in ankylosing. Okay, Dr. Ehda, again, by targeting CD20, rituximab can kill these inflammatory cells, ultimately reducing multiple sclerosis, driving inflammation. Okay, so the rituximab plus natalizumab, one of the biological therapy for multiple sclerosis. Thank you, Dr. Ehda, for confirming this information. Let's move now. Ready, Dr. Sarah? Sorry, Dr. Tasneem. I miss. Dr. Sarah, you ready?
Yes, yes, yes.
Who will be the candidate? I forget again.
Okay. Yes, no problem.
Yeah, who's the candidate?
Sarah.
Yeah, okay. Ready, Dr. Sarah?
Yes, ready.
Okay. Here, Dr. Tasneem, here you go.
Okay. Hello,
Yes, hello.
I'm Dr. Auda Karim. I'm one of Dr. covering the service today. Can you confirm that you are Mrs. Mana, a daughter of Mr. Ahmed, 65 years old?
Yes, doctor.
Are you the next of kin of Mr. Ahmed?
Yes, I'm his daughter.
Okay, so Mrs. Muna, we are here to talk regarding the health condition of your father. After that, I would like to examine him and we can address your concern. Is that okay with you?
Yes, sure, doctor.
Okay, so could you tell me what brought his father here today?
Yes, doctor, my father has been having confusion for the last nights, and he couldn't sleep. And I noticed that also he has odd behavior since that night.
Mm-hmm. I'm sorry for that. This is the first time to happen for him? Hello? Hello? My voice clear?
Yes, yes, doctor.
I didn't hear you.
The first time.
Yes, your voice interrupted. Okay. So
Yes,
does your father he has any trauma before this?
this is the first time. Yes, this is
Okay.
first time.
Okay. Does your father he has any trauma before this?
No.
Okay. So what your father he was doing when this started for him?
I'm not living with him. He is living alone, but the neighbor called me for that, so that I don't know which time exactly the symptoms started.
Okay. So until now he is confused or he recovered well?
Yes. No, it's
Mhm.
he's confused still.
Okay. So did your father he lost any loss of consciousness?
No, he's just confused. He's having like he told me he's seeing things which I don't see. And one time he mentioned he's seeing dogs by his bed, like
Mm-hmm.
that.
Oh,
He's behaving
okay.
strangely.
Okay. So yes, is there any shakiness of his body?
No, doctor, I didn't notice.
Mm-hmm. Okay. Uh, did you check his blood sugar at that time?
No, doctor, we didn't check.
Mm-hmm. Does your father he has like hunger pain, associated shakiness of his hand and sweating?
I don't know, doctor. Since he was
Mm-hmm.
confused, I don't know whether he has this or no.
Okay. So I mean before this. Okay. So what about his orientation? Now, does your father he's oriented to the time and place and person?
No, he don't know where he is, and he don't even he's recognizing me.
Mm-hmm. Okay. I'm sorry for that. Okay. So what about his mood before he has any mood problem?
No, he was okay before this.
Mm-hmm. Any weakness in his body?
No,
Any alter sensation?
no, he
Any
didn't. He didn't
deviation?
mention to me.
Any mouse deviation?
Sorry.
Mouse deviation or any change in
No,
his facial
no,
appearance?
no.
Okay. So okay. Any vision problem for this?
He has no vision problem.
Apart from this, he's seeing object. Okay.
Yeah, he seems.
Okay. So okay. Any high body temperature?
No, we didn't notice that any fever. He has no fever.
Any weight change?
No,
Any lump or bump in his body?
no, doctor.
Do you notice his eyes become more blurred than usual?
No,
Any neck stiffness?
no, he has no neck stiffness.
Mm-hmm. Any loss of control of his water work or bowel habits?
I noticed that he's going to the toilet more
Mm-hmm.
often.
Okay. So does your father he has any medical background I should be aware of?
Yes, doctor. He has high blood pressure and high blood sugar, and he has his doctor is saying he has a prostate problem. I don't know exactly what was his problem.
Mm-hmm. Okay. Regarding the high blood sugar, it's controlled well. Now, what about the accumulated blood sugar reading in the last 3 months?
Really, I don't know, doctor, about this.
Mm-hmm. Are you aware regarding the medication he was taking?
Yes, he's taking ramipril, and he's taking Lantus. He's taking also, I don't know, that's blue pen for the diabetes, and also he's taking medication called tamsulosin.
Okay. Any high blood lipid before?
No.
Does your father smoke?
He quit smoking like 15 years ago, maybe.
Mm-hmm. Okay. Is there any change in his water work regarding the amount, color?
I don't know, but he is going to the toilet
Frequency?
more than usual. Just I know
Any
about it.
burning in his maturation?
He didn't tell me about this.
Mm-hmm. Okay. Any change in his bowel habits before?
No.
Mm-hmm. Okay. Okay. Any chest pain?
He has no chest pain.
Shortness of breath?
No, he's breathing normally.
Awareness of heartbeat?
He didn't mention to me.
Okay. Any joint pain?
No, doctor. My father, before this, he's walking and he's doing his all his daily activities. He's washing and he's walking around.
Okay. Any skin change or any skin rash?
No.
Any
has-
recent illness? Any recent illness before?
No, doctor. Not I'm aware of.
Any past surgical history I should be aware of?
He didn't have any operation in the past.
Okay. I'm sorry for asking these questions about your father. Does your father he took any recreational medications?
No, doctors. No, not he's not taking.
Okay. Does your father he drinks alcohol?
No.
What is his job?
He's retired. Yeah. He retired like maybe 10
Okay.
years.
Okay. Does your father he drive?
No, doctor, he's not driving.
Okay. So can you examine him now?
Sure.
Okay. Yes, I would like to check the vital sign for these patients.
The vital is normal. His blood pressure only is low, 100/60.
Mm-hmm. Okay. Also, I will start examination by examining the assessment of confusion state for this patient, unconscious level,
What do you want to do?
and mental state. Yes.
So I just ask him.
Regarding the GCS. Yes. Now, does your father he aware? Or I would like to ask him if he able to answer for me regarding the time, place.
No, doctor, he's disoriented. Disoriented.
He's totally disoriented.
Yes.
Okay. Regarding the temperature for this patient, is it normal?
Yeah, 37.2.
I'm going to check the barometer drift for this patient.
What you would like to do? To check?
Barometer drift.
Okay, and he's confused, doctor.
Okay. So I'm going for examination, neurological examination. I'm going to check the power.
CNS examination normal.
Cranial nerve, including facial.
Or the CNS examination normal in this patient.
Okay. So I'm going to check the pulse.
The pulse is 80 regular.
Irregular. Okay.
80 regular.
The heart. Auscultate the heart if there is any added sound.
Is no added sound. You can auscultate first sound, first heart sound, second heart sound, normal.
Also, I'm going to check if there is any neck stiffness.
No neck stiffness.
Okay. Also, I'm going to check for lower limb edema.
Negative.
Okay.
What I like to do.
Okay, so apart from that, okay. So does your father he has any nerve problem before, or any stroke or mini stroke before?
No, he didn't have any stroke before.
Any family history of similar condition?
No, no, doctor.
Any family history of not?
No, I don't remember.
Okay. Okay. So can I know what is your concern now?
Just I want to know what is wrong with my father, and he's going to be going back to his normal state like before.
Okay. Actually, after I'm asking you some question after examining him, your father now he presented with this confusion. He has a condition called acute confusion state. In which there is a disturbance in his conscious level, and actually the reason behind this, it might be related to his water work problem, and also we need to exclude the stroke or mini stroke. So what we are going to do now, we are going to admit him, and we are going to run for him some blood test and some scanning to his brain. We need to make a group of specialists in which include the nerve doctor and the group of team to provide him with appropriate plan of care. Is that okay with you?
Right, doctor. Thank you.
Is there another concern for me?
No, doctor. Thank you so much.
Okay, thank you.
Still, you have 2 minutes or 3 minutes, 2 minutes left. You want to ask any or to examine anything else?
Okay. Also, I would like to examine the chest for this patient if there is any crepitations or.
Yeah, he is having crepitation at the left lower zone.
Okay, this crepitation, is it change after cuff, coarse or fine?
A coarse crepitation.
Okay. Okay. So your father, is there any cough before this?
He has no
Screen.
any cough, doctor.
Okay.
It's just one day he's having confusion. Other than that, I didn't notice any cough.
Okay.
One minute left. You want to add or you want to switch to examiner questions?
I don't know if she want to add anything. Just let her finish her time.
Sarah, any question else?
Yes.
Okay. If you're satisfied, you can start examiner questions, please. Dr. Taslim, you can ask here.
Just
Yes.
can you present the case, please?
Yes. Okay.
Your positive finding only.
Yes. Okay. Yes, Mr. Ahmed, Mr. Ali, 65 years old, presented with confusion. since yesterday, and also he's disoriented to time, place, and he has diabetes and hypertension, and also he has a prostate problem. On examination, I find the chest, on examination of the chest, he has crepitations, coarse crepitations, right middle zone. Apart from that, the vital chart is normal, including the blood pressure is hypertensive. Temperature
right.
normal.
So what's your diagnosis for them and for him and the differential diagnosis?
Yes, you will put acute confusion state delirium. I diagnose this because of this chest infection. Might be. Okay. And also, I need to exclude stroke or mini stroke for this patient.
Right. What else?
Okay, hypoglycemia. But again, is that the patient is still confused.
What
Okay.
the last diagnosis? What is the last diagnosis you mentioned?
Hypoglycemia for differential hypoglycemia.
Hypoglycemia, yes.
Mm.
So what else you want to add?
Electrolyte disturbance also.
Right. And so how you are going to investigate him?
Regarding the investigations, I will do basic investigations, full blood count to look for high white blood cells, inflammatory markers, and also I will do chest X-ray for these patients, and I will do renal function test with electrolytes and liver function test also, and also I will do blood culture and urine culture to search for any source of infection. And also I will do CT brain or MRI. Okay. And I will check the blood sugar and hemoglobin A1C and all of the electrolyte, including serum sodium, serum potassium, serum calcium.
Okay, nice. And would you like to do any urine analysis or culture?
Yes, urine culture, yes.
Okay, nice.
Okay, regarding the
yes.
Yes, regarding the management, admission for this patient, stabilization, ABC, and rehydration if dehydrated, and also electrolyte correction if there's any abnormalities, and treat the underlying cause, and education about for his daughter regarding the his conditions, and MDT group of a specialist.
So what's your diagnosis here?
Delirium or acute confusion state.
Yeah, you mentioned that you will treat the underlying cause of his delirium. So what you are going to treat him here?
As the underlying cause, pneumonia. Yes, I will give him antibiotic.
Okay, thank you.
Okay, I will ask here, what image you want to do? Did you mention the image?
Yes, I will do CT brain or MRI.
Or
And yes, MRI, diffusion weight MRI also.
exactly. So you will start with CT brain.
Yes.
And you can, after that, if not diagnostic, you can do diffusion weight MRI. Yes. What else you can consider? Yes. What the most serious cause of confusion and you ruled out by examination in such age?
Meningitis, encephalitis also.
Perfect.
I will do
Perfect.
lumbar puncture also. I forget it.
No, you can consider it, but it's not necessary to be. But you ruled it out by one examination, which is?
And also ABG for this patient is most important.
No. I mean, you did some in your examination steps. You did one step to rule out meningitis, which is
neck stiffness.
yeah. So you ruled it out. So, but I should put it in my differential. Any confusion with
Yes,
immunosuppressed
infection.
and confusion? Yes. Okay. Well done. Thank you, Dr. Sarah. Dr. Tasneem will comment, then I will comment. Please.
She did
Okay.
great. She excluded the causes of the acute confusion state, the infection, the vascular cause, TIA and stroke, and also electrolyte disturbance. And she also hypoglycemia. She excluded all the serious diagnosis. She excluded here, but she forgot to examine for the chest until you remind her. 2 minutes left for her time, just this.
Yeah.
And regarding the investigation and the management is all she mentioned. She did the case well, I think.
Yes. Any other comments you want to add?
No.
Yeah. So it's a good topic and very hot topic. Already a
Yes,
lot of
very hot,
comments.
wallah.
Yeah, in the chat box, I can see a lot of
I know
comments,
it's
which
difficult.
yeah, very nice session. Actually, you did
Yes.
both of you nice session, and you did great. Apart from finishing early in such history and scenario, elderly patient with confusion, you finish before the time or 3 minutes before the time means there is a lot of thing missed.
Yes.
Agree? Agree?
Yes,
Yeah.
exactly.
Okay. So at the examination, one of them, yeah, one of the comments was social. I agree also. How he can cope and who's dependent, who's living with him. All these questions need to be asked because this patient is confused. You don't know he gonna wake again or no. He might be confused. You don't know what's the underlying cause. He might be in a stroke. So it's important to get a lot of social history in this scenario. Okay, back to the complaint and the approach. I will try to do it together again. So the confusion as one of the CNS complaints, it's common in patients, particularly in elderly patients. If young, you will consider meningitis until consider as meningitis until to be confirmed. Okay. Then the onset course duration, as we know, the relevant system here, and you have to ask all CNS questions. The CNS system you should analyze from A to Z, starting from the neurological manifestation, the weakness, numbness, hearing, means cranial nerve, all the cranial nerves, hearing, vision, smelling. You can add even smelling, although it's not important. The mood, the sleep, the movement, the weakness. I mean, here is important. What if this patient presented with weakness, unilateral weakness? So what you consider?
Stroke.
Yeah, so the stroke will be on the top of your differential. But this
Yes.
patient having no neurological deficit or no lateralization, so it could be something else. Still, you can put the stroke one of the differential, but it's not strong differential in this scenario. The balance is important. If he feel ataxic and any eye movement, any question in this system, in this scenario would be relevant, and it can give you a clue. Seizure, one of the important question, and neck stiffness as well. All this question, whenever you remember, you can ask as relevant system. In this patient, particularly, he is with past medical history. You can ask the question of past medical history before the constitutional symptoms. However, if you ask constitutional symptoms in this scenario, it's also important. What do you think the importance of constitutional symptoms in this scenario, Dr. Sarah? What's very important constitutional symptom in this scenario? You have to ask.
Yes, temperature, fever.
Exactly, fever, yes. If he has fever, high grade, low grade, any fever in this scenario, it means meningitis or encephalitis until proved otherwise, right? So you have to ask the
Yes.
constitutional symptoms, starting by the fever, night sweat, a loss of weight, of appetite, although it's not chronic. But if there is loss of weight and loss of appetite, and the duration of the confusion is increasing or being longer, what do you think the case will be?
It's basic
Let's think
ovarian
together.
lesion like print, you know.
Perfect. Yes, this is what I mean. So you have to think widely about a good differential in acute state or in the chronic state. So if you have
Mhm.
chronic symptoms of constitutional symptoms, you have to think about specific myeloid or cancer. Even paraneoplastic syndrome, you can put one of them with hypercalcemia. Any differential you can put. However, you are finding one of these constitutional symptoms is or are positive. Now the time for past medical history, diabetes and the complication of diabetes. You can screen this diabetes from A to Z, particularly in this scenario, as well as for
Mhm.
hypertension. So let's start by diabetes. The most common question you have to ask in diabetes. What do you think? Particularly in this
Since
scenario.
when you have been there?
Exactly. So then this
Okay.
is the first, yes.
Since
For
when
how
you have been
long?
diagnosed with this, yes.
Yes.
What medication
Yes.
and adherent to his medication or not?
Exactly.
And what's the last
Compliance.
accumulated blood sugar?
Perfect.
Yes.
And
Yes, and after
very
that,
important.
regular follow-up, diabetic clinic
Okay.
and dietitian follow
Yes.
advice.
Okay. One more question.
After
Important.
that, I'm going to say
Still,
any recent change in his medication also.
okay. This is
Recent
regarding
change in
medication.
as the type, yes, of what kind of medications is it? Tablets, is it insulin?
Okay. If you find insulin,
Regarding the dose also
what?
and other complications.
Yeah. If you find insulin,
Mhm.
what you will do if you find
Yes.
insulin?
I will ask regarding the dose.
Sorry. If you find insulin.
Yes, the
Okay.
dose, the type of insulin, and the dose, and yes, injection site also. It's the important.
No, these are the mechanism. I'm
Yes.
talking about complication of insulin related to this scenario. هلا.
Yes, if he yes change his injection site because it can cause hypoglycemia, low absorption, or high absorption, and hyperglycemia also. And both of them, it can cause confusion for this
So yeah,
patient.
exactly. This is not what I ask and what I need from you to ask. How is the hyperglycemia? Does he have any of hypoglycemic attack before? Why you consider this question
Yes.
important?
Because it means that
He's had
it can happen again.
exactly. Yes, he has risk to be in hypoglycemic coma now.
Yes.
Maybe.
Yes.
So if he's not compliant and he has previous history of hypoglycemia, I can say most possibly one of the differential hypoglycemic coma. Why not?
Mhm.
Then the hyperglycemic
Yes.
complication you mentioned already, and you can pick up it from the hemoglobin A1C. If you find this patient, he told you that daughter, she told you,
Control.
yeah, he's controlled, so you can tight control. You can think about hypoglycemic coma, or
Mhm.
he's not controlled and his blood sugar is high. So you can say this is possibility of
Hyperglycemic coma.
hyperglycemic complication.
Hyperosmolar hyperglycemic coma. Yes.
Exactly, you have
Thank you,
hyperglycemic
Dr. Farah.
hyperosmolar or even DKA. Some patients
Yes.
he also might be present with the DKA, particularly if he has the abdominal pain, vomiting. So you will have other manifestation of DKA. Okay, back to the
Mhm.
you finish already screening for diabetes. Although you can ask more about the retinopathy, nephropathy, but you can ask them in the systemic review. Okay, but
Mhm.
at least you have to know in general, grossly, how the diabetes condition for this patient. The hypertension now. What do you think the importance of hypertension as related to the case?
Medication. If this patient he took diuretics,
Exactly.
It can
Yes,
cause
maybe
electrolyte disturbance,
this is one of the possible.
hyponatremia.
Yeah, hyponatremia.
Yes.
Yes, I agree. What else?
And also at the ischemic risk for a stroke,
Perfect. Due to either hyper
hypertension,
or hypotension.
and
What else?
hypertensive encephalopathy also.
Yes, this
Hypertensive
is
encephalopathy
important.
also.
Yes, you have to remember if this patient uncontrolled hypertension for the last 3 days or for 3 weeks, he's always hypertensive, 190 or 200. Definitely, you can say this is hypertensive encephalopathy patient, or ICH, intracranial hemorrhage, due to again hypertension,
Yes.
uncontrolled
Stroke,
blood pressure.
hemorrhage, stroke.
Or in the opposite side, the medication itself can lead to either the erectile dysfunction or the even hypotension can cause what's called, do you know Brest syndrome, posterior circulation encephalopathy syndrome? This is also one of the
Yes.
possible complication due to watershed area hypoperfusion because of a rapid
Mm-hmm.
connection of high blood pressure to hypotension. So you can put a lot of differential from only the past medical history. Okay, so you can put metabolic
Yes.
and electrolyte disturbance and hypertensive encephalopathy. Without, still, we didn't proceed for the systemic review. Now the time for systemic review, CNS already asked earlier. You have to ask about others. So intolerance to any weather, maybe it's something related to thyroid. Do you think? Do you think the thyroid can lead to coma? What condition related to thyroid can lead to confusion?
Myxedema, coma, myxedema.
Perfect. Yes, this is one of the possible differential. If you have noticed one of the positive finding in the history related to the hypothyroidism. So that's why we are doing for such age screening by doing thyroid function tests. Simply, the patient might be hypothyroidism and he has either hyponatremia severe due to hypothyroidism and it's the cause of coma, or the myxedema coma due to severe hypothyroidism. Okay, that's why the systemic review is important. Even one question. The next question or next system, cardiovascular. Do you think it's any importance to ask about cardiovascular in this scenario? Please, you tell
Yes,
me.
if this patient he has
Yeah.
yes, like infective endocarditis can cause confusion also.
Why you are thinking about infective
Or
endocarditis? Another something common in
as a part of
hypertensive patients.
infection.
Hypertensive
What?
patient,
In
hypertensive
yes,
patient.
cardiomyopathy, heart failure,
Yeah, one of them
heart
yes,
failure.
heart failure, ischemic heart disease. Why not? So you ask about chest pain,
Mhm.
awareness of heartbeat. Yes, he has
Yes, my
history of
car.
chest pain. So you can simply say
Yes.
this patient is ischemic heart disease patient. You can diagnose it. Awareness of heartbeat may be also related to palpitation. AF may be related to the stroke. Stroke would be the case. So you have two
Mm-hmm.
questions in cardiovascular can lead to two conditions, might be the differential. Chest pain, ischemic heart disease, heart failure, or palpitation or awareness of heartbeat due to lead to, for example, showers, AF, and patient would be the stroke. Next system would be the chest. Any short of breath? Do you think there is possibility to have short of breath? Can be if he is hypertensive, for example, and he has attack of hypertensive pulmonary edema. Could be one of the post or positive or possible complication due to uncontrolled hypertension. We are thinking widely again. You can pick up some of the finding from the history could be the case because of it. Okay, so hypertension can lead to ischemic heart disease, heart failure can lead to also the pulmonary edema can lead to hypertensive encephalopathy. However, in this scenario, patient blood pressure is low, but I'm talking in general. Okay, the GI questions. What do you think the GI important question in this scenario related to the case we mentioned earlier?
Infective diarrhea.
Diarrhea,
Diarrhea,
yes,
loose motion.
exactly, yes. By the way, the
Mhm.
chest symptoms, one of the finding is related to the case, which is pneumonia, and the patient took antibiotics, for example, or the pneumonia itself can cause delirium. So
Yes.
it was one of the point in the systemic review give you the clue.
But when I'm asking regarding the cough,
Yeah,
negative,
cough or
and that is why I'm not examining
short
the
of
case.
breath.
Shortness of
I
breath,
think
negative.
Dr. Tasneem, there is history of cough or short of breath. I think.
Yes.
I-
Yes.
Because the daughter is not living with her father,
yeah,
that's why
so
she knows about him.
yeah, so at least
Oh,
she will
تنت
give you
ضيعتني أنا.
supposed to give positive history of either short of breath or cough. Okay, along with fever, of course.
Yes, yes.
Okay, back to the GI. You
كله
mentioned gastroenteritis, diarrhea can lead to dehydration and hypotension,
And
coma.
one thing, doctor, just
I
I want
agree.
to comment. In the elderly, the pneumonia can present sometimes in the elderly without the typical presentation, without cough, without fever.
But not in basis wise.
Okay.
Okay, this is why they should give you a clue how to think this is the possible differential if you don't have one of the manifestation. So they have to give you. Okay, back to the GI, diarrhea, gastroenteritis, dehydration, confusion, agree. What else? Constipation, elderly, again, it can lead to confusion, particularly in the elderly patient. What else? Abdominal pain, vomiting, DKA, again, confusion.
Yes,
So
okay.
a lot of possibility. You can pick up any of them from the systemic review. Okay, next system would be the urine. Any change of the urine amount, color, blood, porosity. Give me one condition you could pick up from the genitourinary system. Positive finding in the, for example, polyuria. If this patient is having polyuria, what condition you know it could be a cause of his confusion?
Hypercalcemia.
Perfect.
Hypercalcemia,
Yeah, yes,
hyperglycemia.
yeah, yes, that's it. That's it. Hypercalcemia. So polyuria and confusion and abdominal pain, bone pain. Okay.
Constipation.
Yeah, from the systemic review. I'm trying to
Yes.
stress the systemic review
Yes.
because it can help you in the differential or at least the diagnosis. Okay. The musculoskeletal, any joint pain,
Yes.
any muscle pain, any bone pain. Bone pain, again, hypercalcemia. Muscle pain, it's not, maybe it's not related or joint pain, yes, hypercalcemia again can be can lead to the joint pain. Okay, next, the social, family history, travel history, HIV. You can add to this system or this question. The impotence, it could be related, but it's not the time because patient already confused. Okay. Do you question?
Yes.
Do you smoke? Does he smoke? Does he drink alcohol? Does he drive, which is important in this scenario? And what's his job? Retired. So you have to ask whose home he's living and how he cope with his daily activity and offer support. Finish and the examination, you did great. I like when you ask about the pronator drift. Most of us forgetting the neurological examination while doing the neurological examination, doing the pronator drift. It's clue for your stroke or your patient if he's having stroke. If there is positive pronator, you can say 90% this patient is having upper motor neuron, and possibly with the confusion, you can think about stroke. Clear? Other examination, yes, the GCS, not merely mental, because I think this patient is not awake to talk about or to ask him about the mental state.
Yes, GCS.
So the GCS, Glasgow
GCS is
scale,
very important.
is the most accurate
Yes.
test in this scenario. Okay. Now, yeah, I think the case will not be out of these differential, as already most of them of us mentioned and the candidates, sorry, in the chat box. So metabolic, electrolyte, hypoglycemic, confusion state, delirium due to infection, either chest or the urinary system. By the way, the urinary question also can lead you, it can guide you to, again, UTI. It can be reflected to the brain as a delirium because of urinary tract infection. And it's common, by the way. Most of patients just simple UTI, he will be in confusion. So our case was about pneumonia precipitating acute confusion state. But the diagnosis as a concern, yes, your father is having what's called acute confusion state, and possibly related to pneumonia or medication. We will figure out the cause after doing some blood test and image. A stroke, one of them, you have to put because he's having risk factor of atherosclerosis, either because of diabetes or hypertension. Possibly he's having also dyslipidemia. Okay, I think this is the case. Any question from Dr. Sarah, Dr. Tasneem?
No, doctor. No, doctor. Basil, thank you.
Perfect. Yeah, good informative session and performance as well. The first time also, Dr. Sarah. It was great. But try again to ask more questions regarding the social and to know exactly what, from the system view, what you should examine. Okay. Maybe by mistake, Dr. Tasneem didn't mention the chest, but I hope it would be clear in the exam. They will give you a clue from each system and try to write down what you should examine
Yes.
while taking the history, as I mentioned earlier. Okay, any question?
About silent disease infection, it can be UTI. The UTI come by silent, really. If
Yes,
the
you're
patient
right.
has history of like prostate like that, we can consider it is a first differential here.
Yes,
But in pneumonia, really, they should bring a clue, even chest pain or
exactly.
cold recently. He has been
Yes,
cold recently or any
Yes,
chest
that is
pain.
why I'm not going to examine the
yes, you're right. Yes,
Yes.
but UTI can
But
pass.
UTI you can consider
Exactly.
without
Yes.
any symptoms, even if
Yes,
he has no any prosthetic problem or anything.
yes, you're right, Dr. Aisha. Thank
Because
you.
really it is silent in, especially
Yeah,
in men.
exactly with
And
prostatic
also,
hyperplasia.
it
Yes,
is
you're
a
right.
very common cause of confusion in old age.
Yes,
The UTI first, then the hyponatremia, also silent. Maybe
I,
poor nutrition like that.
yes, I agree.
Dehydration, like being in hot weather.
Yeah, thank you, Dr. Aisha. So you can add a particular question for, or it would be in the past medical history, maybe the patient is just having BBH, and the BBH could be the reason behind the UTI. Okay, most of the elderly patient having BBH, that's why they have recurrent urinary tract infection.
And even in practice, Dr. Basim, when we having the age in confusion, we first doing catheterization, even and getting the urine sample. It was
Mhm.
very common.
Yeah, and
So
urine
the
analysis,
first
one
thing
of the
you
routine
will
tests we
do
are
for
doing.
taking
Yes, you're
sample.
right. Sorry, Dr. Aisha?
Yes, and doing catheterization, yes. It's
Yeah,
very
and
common to do,
exactly,
maybe after ultrasound or maybe before.
you're right.
If you can
I-
take sample, because if he confused, how you will take the sample from urine.
Yes, you're
So
right.
they doing it for sampling also.
Yes, you're right. So we are putting or inserting Foley's catheter in order to drain and at the same time to do the urine analysis. It could be having some nitrate or pus cells. Then you can say this is related to the UTI and you can treat the patient. Thank you for this comment, Dr. Aisha. History of any infection recently, you can add it to the history, plus in history of any medication. Any added medication is very important in such age with such history of long-standing disease. Patient might be depressed. By the way, this is one of the scenarios. Patient might be depressed. He's receiving antidepressant, for example, the amitriptyline, right? And he might have SIADA, syndrome of inappropriate antidiuretic hormone. This is also one of the possible differential. But it could be in the history taking with history of depression and patient take or have taken antidepressant. Okay?
Doctor, Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh.
Also, I want to comment on cardiovascular
Yeah,
investigations.
continue.
Comment on ECG and echocardiography to be added to a usual investigation for this case.
Agree
Is it
100%. Yes, absolutely right.
also blood for sugar? It must be remembered first, not to be added late. As a routine investigations, CBC and blood sugar, fasting, hemoglobin A1C.
Absolutely
During
right.
this, yes, must be added first.
Of course, you have to. Whenever you have diabetes and
Yes, because the
hypertension.
patient is hypertensive and diabetic.
Yes, exactly.
Blood sugar must be mentioned first, I think.
Okay, I will ask you one more profile you have to do, Dr. Omar.
Yes. But I want to comment on cardiovascular investigations and blood sugars or
Okay,
sugar profile for this patient early,
okay,
not to mention late.
okay. I will add this question for you. Since you add some investigation, what other profile you can add to this patient important in this scenario?
Yes, electrolytes.
Full
Uh,
electrolytes, finish. Okay,
yes,
what else?
CRP and ESR.
Okay,
And also you can do this thyroid
perfect.
investigations
Yeah, this
also.
is what I want you to
Yes,
say.
yes.
Plus thyroids and one more important related to the stroke and
Synaxin test also you can add.
no, it could be okay. You mean for Addison because of hypotension?
Yes. This is comatose patient or in patient in confusion state. You did
Okay.
not know what is the
Yeah,
real cause for
that's
this
why you
patient.
have a lot of investigation you can add,
Yes.
but it could be
As
it would be related to the differential.
yes,
lipid profile.
Yes, lipid profile. This is what
renal
I wanted
profile,
you to say. Yes, lipid
liver
profile.
profile also.
Yes, important. Yes,
Also, you can add this for lipid profile also, because you suspect of cardiovascular,
yes,
uh, like stroke.
yes. You're right.
So
And also B12 and folate.
I agree with this also. B12 and folate as diet habit. Yes, a diet habit question. He might be, but he will present with other manifestation of B12 and folate. For example, pins and needles. However, it could be masked by diabetes. But ataxia, all these things could be associated, and it would be in the history, right? But still, yes, you can add them to the routine test. You don't know what's ongoing with this patient.
Mm. Yeah, I think also examination, need BR examination. I will offer BR examination because constipation itself can be one of the causes of delirium. This is patient delirious. He has confusion state. Constipation, one of them. So I will offer PR examination in the
Yes.
investigation ECG because sometimes MI just come with confusion.
Mhm.
And I think she need to just deep history
Yes.
in the social history, because this patient sometimes confusion can be just a sign of depression. This patient may be depressed only. So that's why we need with whom he's living, who's caring about him, how he take his medication, if there is any polypharmacy, all the medication given to him. Polypharmacy itself can cause confusion. So more details on these things also, I think she need to add. I agree with the folate and B12 because this is a part of confusion screen. So confusion screen, it is hematinics, B12, and folate, thyroid function test, CT scan. So this is the confusion screen for any patient with confusion screen.
Yes. Yeah. Thank you, Dr. Maida. Good comment, of course. Yes, particularly in elderly patients, you have to do this as screening. Okay. Some doctors, Dr. Dua, travel history, Dr. Zohair, travel history, is it related here? If you suspect, for example, meningitis, brucellosis, some endemic, but it's not the case here. But try to make it as a habit. Even TB meningitis can be, but it's not the case. But travel history and any infection is important. By the way, any infection, you have to ask about travel history. One of the important question you have to do. Okay, Dr. Zahir. Yeah, back to Dr. Oda question. Is it possible to have this case in basis? Yeah, sometimes they brought such cases. Okay, alcohol as well, perfect. Dr. Hoda mentioned GCS. Again, we mentioned already. Aspiration can cause short of breath if he is confused. Yes, so it's important to secure his airway. ECG, yes, we mentioned. MIAF, yes, you're right. MI, treatment of rehydration, antibiotics, correct metabolic disturbance. Dr. Ilaf missed the case. So what's the diagnosis of this case? It was pneumonia precipitating factor for delirium. Hypertensive encephalopathy, I agree. Dr. Oni. Hypoglycemia, masked, your Dr. Hoda. Hypo or hyper, you have to put. Change in the environment. Also important to us about his baseline cognitive wise. Yes, I agree. As dementia, it might be, but the onset will give you a clue. Is it something acute or chronic? If chronic, so you can say dementia, one of the differentials. So the patient having this since long time because of isolation, for example, changing the area, staying alone. Okay, so it could be the case, dementia. But in the acute state, it's called delirium. So our case was about acute state, so it's called delirium. Dr. Huzaifa, also it could be related medication. We mentioned already polypharmacy by Dr. Mahida. Any change in this medication recently? Agree. By the way, polypharmacy means patient is taking more than 5 medication or 5 tablet. So it's called polypharmacy. Need to rule out smoking and alcohol, of course. To rule out constipation, yes. Hyperglycemia, ultrasound for retention. Dr. Aisha, thank you. Dr. Maida, PR examination, chest X-ray, ask about constipation. Metabolic electrolyte, full electrolyte. By the way, you have to say full electrolyte because most of the electrolytes, hypo or hyper, can lead to confusion. Some of them can lead to seizure. So hypo or hypercalcemia, hypernatremia, hyperphosphatemia can lead to all of them can lead to the confusion. Hyperkalemia cannot lead or cannot cause magnesemia as well. But I think hypermagnesemia or hypomagnesemia, yeah, because of epilepsy, they are using it in the epilepsy. So hypermagnesemia can lead to CNS depression, hypermagnesemia, because it's used in the preeclampsia. Honk, yes, but it's not called honk anymore, Dr. Ahmed. It's called HHS, hyperglycemic ketotic state. Hyperglycemic state. Hyperglycemic state. No more honk. Due to the diabetes, I agree. Hypoglycemia, we can mention. Dr. Maida, what this can lead to by himself, eating, the drinking, of course. Dehydration itself, patient neglected, living alone. He can be presented with confusion. Many may have HHS, already mentioned, abdominal examination, dehydration. Alcohol, smoking, yes, sure. She missed all this history, social and alcohol. Home, living with home, yes, thank you. I think we cover all comment. What is the confusion screening? Yeah, so you can do the whole routine test, adding to the vitamin screening and hormonal screening. You can add in screening for infection, and you can the image. You can do CT brain, started by CT brain. After that, you can do MRI diffusion weight scan if you are not finding anything in the CT brain. Definitely, you can say the multidisciplinary team approach. This patient is having a lot of disease and a lot of finding. Okay, abdominal ultrasound for bladder we mentioned, and not only bladder, ultrasound for bladder and prostate. Alcohol toxicity withdrawal. Yes, if you have had alcohol, you have to screen for alcohol, either high toxicity as binge drinking or chronic alcoholic. Okay, so he's exceeding the limit. Yeah. Okay, thank you, Doctor. Any question before ending the session? Any?
Thank you, Dr. Basim, for this
Yes.
session and for your time. Just suggestion, if you started the session earlier, if your time schedule allow.
Dr. Sarah, believe me, when I started at 10 and at 10:30, the same attendance. sometimes even the candidate asking to be late. Wallahi, I try my best.
Okay,
So,
thank you, doctor.
yeah, but believe me, both attendance either 10 or 10:30 or 11. Okay. Sorry for
Okay.
being late. I know some of doctors having late time, but I'm trying my best to just adapt to the time suit for me and for others. Okay.
Okay.
Thank you,
Thank you.
doctor. Thank you.
Okay, Dr.
Okay.
Bassem.
شكرا
Thank
جزيلا.
So helpful. Thank you.
Most welcome. Dr. Maida, add confusion screen include electrolyte, thyroid function, hematinics, yeah, for iron, folate. Okay, thank you, Dr. Maida. Again, thank you, Dr. Dr. Tasneem and Dr. Sarah. Thank you, everyone. Anyone has comment or question before ending the session? Okay, great. Satisfied all. So we can end the session. See you tomorrow with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. شكرا دكتور عمر. شكرا.